Dr. Pippa Newton. I'm one of the consultants in infectious diseases, and I'm going to talk to you today about Amphotericin B. By the end of the talk, I'd like you to have learnt several different learning objectives, as you can see on the slide here, to know a little bit about the mechanism of Amphotericin B, the spectrum activity of this drug, some of the important pharmacokinetics associated with it, and then obviously then go on to talk about the clinical indications for this treatment and potential adverse effects that can be associated with Amphotericin B therapy. Amphotericin B was originally described and discovered by Gold in 1956. It was picked up from a soil sample, and he isolated the Amphotericin B from a Streptomyces nodosus strain of bacteria. As you can see, it became the first systemic antifungal in 1958. It has a broad spectrum activity against different yeasts, molds and dimorphic fungi, but also has activity against some protozoa such as Leishmaniasis. It's a very large molecule and has both hydrophobic and hydrophilic components, and is therefore described as being an amphipathic in nature. And as you can see, it has quite a large molecular weight. This is quite a complicated structure, but as you can see, there's several different components to Amphotericin B. It has within its structure elements that will react with both acid and with bases. It has a macrolide component to it as well, and also has a lactone ring, which has both ketone and hydroxyl groups. And in addition to that, it has a polyene chain, as you can see, with multiple double bonds throughout it. It binds irreversibly to membranes which contain ergosterol, and within the fungus that it's binding to, it causes initial binding and then a transmembrane permeabilization, so it actually forms a transmembrane channel. And if you see that on the right, it initially binds to the ergosterol within the actual membrane, and then changes its shape to form a pore, which then allows fluids, etc., to leak out of the cell. And it particularly allows electrolytes such as sodium, potassium, chloride to leak out of the cell. And as the pore enlarges, you can lose macromolecules as well. In addition to that being its main action with fungi, it does have other actions, as you can see on the slide, including release of nitric oxide, intermediates, and has actions where it can release pro-inflammatory cytokines such as TNF-alpha and interleukin-1. All these effects on the cell in causing the pores to release all the electrolytes and macromolecules, and also the pro-inflammatory cytokine actions, etc., eventually result in damage to the cell and cell death. There are several different formulations of Amphotericin B. The conventional form is, as you can see there, the deoxycholate form, but more recently there have been lipid-based formulations, of which several are named on the slide, including liposomal Amphotericin B, the albicet, the lipid complex, and also the colloidal dispersion complex, but there are other formulations as well. And we'll talk a little bit later about the reasons for using the more lipid-based formulations these days compared to the conventional form for most treatments that we do today. The newer Amphotericin B formulations have a better side effect profile compared to the conventional amphotericin. As you can see, it has fewer side effects, and this is primarily because the amphotericin is often within a lipid component such as a vesicle. As you can see on the right hand side, it then gets taken up within the macrophage by a process of endocytosis. It fuses with a lysosome, and then over time that lysosome degrades and releases the drug. So that's the way it's taken up from the blood into a macrophage and then subsequently gets released into the tissues. So all the new forms of amphotericin are lipid-based, and we'll talk about those different structures later on. As a result of that, it has less toxicities from an infusion point of view and also has less renal toxicities. As you can see on the left-hand side of the slide, there are different tissue penetrations to be aware of. So this form has slightly less penetration into the kidneys and into the lungs, but better into the liver, spleen, etc. What I would say on a dose-to-dose basis, the conventional amphotericin actually is more potent than the liposomal form. From a fungal point of view, it has a broad range of activity with three main groups, including yeasts, molds, and also dimorphic fungi. If we show this slide, just looking at amphotericin B in the first column, followed by the triazoles going from fluconazole up to posaconazole, and on the left-hand side a list of some of the different yeasts, dimorphic fungi and molds that you can see there is differences in their spectrum of activity. So if you look at Candida species, for example, there is a hole with amphotericin B in that it doesn't cover Candida lucinaceae, while fluconazole, itraconazole, for example, do. When you look at the Aspergillus species, as you can see, amphotericin does not work against Aspergillus terris, and that's inherently resistant to that. But it works for the majority of the others, and we'll talk about that later on, although some will have quite high MICs to take into account. And then going through the lower part of the slide, you'll see that there are several dimorphic fungi, which it does have some activity against, while some of the other azoles don't. If you compare in the middle things like histoplasma and coccidioidomycosis, you'll see it has some better activity than, for example, like voriconazole and a similar activity to posaconazole. There are some holes in the armoury of amphotericin. As you can see, there are some species that are intrinsically resistant, of which we've mentioned already Aspergillus terris, but as you can see on the slide, there is resistance for Aspergillus nigilans as well. And Scedosporium species have intrinsic resistance, although with some of them, if you can see on the right-hand side of the slide, if the you have to have very high drug levels to have any activity, because quite a few of these pathogens you need they're quite high MIC, so the minimal inhibitory concentration needed to overcome and have activity are quite high for some organisms, including Aspergillus flavus, but some of the Scedosporium species as well. It's very rare to have intrinsic resistance against amphotericin. And this slide just shows it to you in a different way, the species that have intrinsic resistance, such as Terris and Nigilans and Scedosporium. Some where you need reasonably high drug levels because of the higher minimally inhibitory concentrations required to gain activity of amphotericin against these organisms, such as Candida krusei, and at the end the very rare ones that have got acquired resistance. If we look at the different formulations of amphotericin B, and you can see the characteristics that we're going to look at on the left-hand side of the slide, then the first column is the conventional amphotericin B, and then three different lipid formulations of amphotericin B. You can see that there are quite differences between them, both by the percentage of amphotericin within each of the different components. The amphotericin B conventional has a lipid configuration of micelles, but the others are either vesicles, discs or ribbon-like structures, which we'll show you in a second. But just looking at the diameters, they can be quite small to the largest one, which is the disc-like on the right-hand side. it's very important not to mix up the formulation of amphotericin that you're using. As you'll see, there are quite different dose recommendations, with the conventional amphotericin in the first column having the lowest dose range per milligram per kilogram, compared to the others which tend to have at least a 3 mg per kilogram dose. If you look at the pharmacokinetics, liposomal amphotericin has an increased peak or maximum concentration within body systems and a higher area under the curve compared to the other lipid formulations. And all the medications can have some nephrotoxicity, of which conventional amphotericin tends to have the highest overall. When you give amphotericin, it can cause infusion reactions, and these are particularly noticeable with the conventional form, although do occur in the other forms, but less frequent with the liposomal amphotericin compared to the ribbon and the disc-like forms of amphotericin. This is quite a complicated slide, just looking at the structure of the different lipid Amphotericin B formulations. If we start on the left-hand side of the slide, the amphotericin links in with different carrier lipids, and as you can see at the bottom, it tends to link in with DMPC and DMPG, and it links in between to form a circle, and then those circles are linked by a ribbon formation to form an associated complex. The second formulation in the middle, which is the disc-like particles, as you can see, uses a slightly different lipid carrier, the cholesterol sulfate, and they form complexes around with initially the cholesterol sulfate, then the amphotericin, and alternatively like that to form a disc-like structure. And as you can see, this is a slightly smaller size compared to the ribbon-like particles on the left-hand side. On the very right-hand side of the slide, they form the amphotericin forms with a liposome, and the carrier lipids again are slightly different, HSPC and DSPG and cholesterol. And this is the smallest formulation of the liposomal or the lipid formulation of amphotericin. All these formulations are given parenterally, and they're well distributed throughout the body. They have a half-life that can last for about 2 weeks or so, and can definitely detect this drug in the urine even a week or so after stopping treatment. They are very protein bound, and therefore patients who have end-stage renal failure, it doesn't come off on dialysis. And as you can see, a good proportion of the amphotericin is excreted unchanged either in the stool or in the feces, in the stool or the urine. Amphotericin B is an important antifungal agent, and as you can see on the left-hand side, there are many important clinical indications for that, including first-line treatments for histoplasmosis, cryptococcal meningitis, the protozoan at the bottom, leishmaniasis, but again you've got mucormycosis and some of the and penicilliosis as other first-line treatments. There are other indications as indicated on the right-hand side, including invasive aspergillosis and candida, and things like coccidiomycosis, etc. There's a whole range of different indications, but the ones on the right-hand side, there's a broad spectrum of activity, and often are used empirically in people who've got invasive disease. The dose of amphotericin B, the conventional dose, is lower, usually at between 0.7 and 1 milligram per kilogram per day, and that's a similar dose in paediatrics. In the adult doses, as you can see, we tend to use this treatment, the liposomal form, at a higher dose compared to the conventional, and we use it in 3 main settings: in patients who need empiric therapy, who are neutropenic, who have not responded to broad-spectrum antibiotics and you're worried that they could have a systemic fungal infection or invasive aspergillosis, and then you would give that dose at 3 mg per kilogram per day. Can be used for other systemic fungal infections and also is commonly used in cryptococcal meningitis, but at a higher dose of 6 milligrams per kilogram per day. There are similar dosing patterns for children. If anyone's given Amphotericin B through an infusion, patients do experience infusion-related reactions, and this is particularly seen with the conventional form, but does occur with the lipid formulations as well. And the common side effects are fevers or chills. Patients may have nausea or vomiting, and they can get an anaphylactic-like reaction and also get hypertension and hypoxia. And most of these effects are thought to be due to their reaction on pro-inflammatory cytokines, stimulating and causing these symptoms. It does have a significant renal hit and can cause nephrotoxicity in over 50% of patients, and this is a combination of due to vasoconstriction, but also effects on the distal renal tubular membranes. And as a result, patients who are on amphotericin need to have their renal function closely monitored. They tend to be at risk of losing both potassium and magnesium. They can also develop a renal tubular acidosis, some of which may not be reversible, and quite commonly they can actually release an impairment of renal urinary acidification. And as a result, renal acids do accumulate, but they tend not to get a systemic acidosis associated with that. The impaired urinary acidification can actually occur and last for a few months after stopping amphotericin, but over time tends to settle. Well, as I've mentioned, the renal tubular acidosis, a good proportion are reversible, but sometimes they can be long-lasting. The other adverse effects that can be seen with Amphotericin B are listed on this slide. Patients commonly experience GI symptoms such as nausea and vomiting. They do have electrolyte abnormalities, often hyperkalemia, and they can have problems with their renal function, and that's why it's very important that we monitor those. The very other common side effects to be aware of: they often feel quite tired and lethargic. They can cause an anemia, which can be noticed usually 1 or 2 weeks into treatment rather than initially. They may get GI symptoms such as diarrhea and headache, and can, as we've talked about before, affect their kidneys and develop an acute kidney injury. If you give the infusion too quickly with some of the liposomal forms, you can get bone pain, which can be very uncomfortable, and slowing down the infusion will often help alleviate that. At the left-hand column, you'll see that it's rare to get anaphylaxis, but it is described with amphotericin. And this is just one case series of 2 patients who were treated for leishmaniasis who got an immediate hypersensitivity reaction to Amphotericin B, developing hypotension and breathlessness, and one that developed facial edema as well. So as well as the hypersensitivity reaction, just watch out for the renal dysfunction as well, which is, as we said, quite common in Amphotericin B treatment. If you're giving Amphotericin B, there are several things that you need to be aware of when giving the infusion. If you use the old conventional form, it is quite irritant to veins, and so we tend to use a central access, central line for that. That's not necessary with the more frequently used lipid preparations. Historically, people have given a test dose of amphotericin and given 1 milligram over 10 minutes and then waited half an hour before continuing the infusion. But most of these days don't use a specific test dose like that, but instead run a small volume, about 10 mils of the infusion, over about 5-10 minutes, and then wait 20 minutes to make sure that they've not had a severe reaction or going to have an anaphylactic reaction, and then complete the infusion. As we've talked about, there are infusion-related side effects such as nausea and vomiting, fevers and chills, and that is slightly dependent on the rate that the infusions are given. So for the lipid formulations, we tend to start an infusion over 2 hours initially, while the more conventional, you may need to start it even slower at around 4 hours. To try and avoid the renal dysfunction, we want to prehydrate patients with intravenous fluids, and you may need to do that on a daily basis or ask them to increase their oral intake as well. It's important to monitor their electrolytes, and this would be daily for the first 5 days, and then 2 or 3 times a week thereafter. And also check their electrolytes, watching out particularly for their potassium and magnesium. And you can use amiloride to try and reduce potassium loss during this time, but obviously make sure patients are well hydrated because of the renal toxicity risk. I'd also recommend that you look very carefully at their drug chart to see whether there's any other nephrotoxic drugs that could be stopped during that time, and if possible you may need to consider avoiding intravenous contrast as well to reduce the risk of the renal injury that could occur with patients on Amphotericin B. As you can see near the bottom of the slide, that some patients do develop anemia, and I would be looking out for that and monitoring that just after a week of duration of treatment, but for the next 2 or 3 weeks thereafter, and they can get to a point where they actually need a blood transfusion due to the severity of the anemia that can occur with Amphotericin. What I would say at the bottom, and I think is an important part on the slide, is that you don't want to be masking any severe symptoms, and so we would try and avoid giving hydrocortisone with people having infusions, because that may start to mask complications such as the anaphylactic reaction, and we're better to control the fevers and the chills with things like paracetamol or simple analgesics. So in conclusion, we've talked about Amphotericin B, and it's the first systemic antifungal agent available, and it was initially introduced in 1958. We've talked about the spectrum of activity, primarily looking at yeasts, dimorphic fungi and molds, and be aware that it does have other activities as well. We've talked about some of the important side effects, including the risk of renal toxicities and infusion reactions, and the rare complication of an anaphylaxis. As you know, that the lipid formulations were introduced later on, and they have less renal toxicities than the conventional form, and they're not as potent as a conventional form from a milligram per kilogram dose-wise. It's a drug of first choice for several important systemic antifungal fungal infections, which were shown on a slide earlier, and is the only drug that you can use in a patient who's pregnant, because triazole therapies are actually contraindicated in that situation because of their teratogenicity. Thank you very much for your time. There we are.